an Ohio location. I want to wholeheartedly thank each of you for being here and taking the time of your busy schedules to be here with us today to learn about what we do and why we do the things that we do. So without further ado, I'd like to introduce Dr. Deana Kimes, and she can go over the things that she has. Thank you.
Thank you, everybody, for being patient and waiting. We got right up to the last minute here. So we got the audio, visual things set. So my name is Dr. Kimes. So I have been with BrightView for about 4 years now. I am the Ohio State Medical Director. I'm board certified in both emergency and addiction medicine. And I got into addiction medicine from the emergency department, seeing all the negative consequences, all the horrific things that we see. And it kind of prompted me to want to learn more about addiction. Because believe it or not, we really didn't learn that specialty so much in medical school. So that did prompt me to further my education and get the board certification in addiction medicine. And I absolutely love it. It is so rewarding to see people's lives turn around like that. So it has its challenges, but it's absolutely a wonderful challenge to have. And when you make those differences in the people's lives, that's what makes all the difference to me. This is kind of an informal lecture, so if you guys have any questions that come up during the presentation, please just raise your hand and we can answer them now, or we could at that time, or save it to the end. Up to you. I don't mind. I can certainly answer as we go. So here's our learning objectives. We want to kind of go over the far-reaching effects of substance use disorder, understanding that it's a disease and it is treatable, learn how to reduce stigma, and we'll touch on some current drug trends and recognize the benefits of medication and treatment for the opiate use disorder in particular, understand what you guys can do to help. So substance use disorder is not any surprise. It has far-reaching effects. I think everybody here understands. But according to the CDC, 1 in 7 Americans reports to experiencing a substance use disorder. It affects 21 million Americans, and that's 8% of our nation's population of over 12 years old. And only 10% really seek treatment. So that's what is just as disheartening. The effects of it aren't really just it doesn't just affect the person, but it also affects their family. It affects the whole community. So it is a disease that just has its fingers out there in every community. It affects all races, ages, persuasions, socioeconomic groups, and communities. A person afflicted with substance use disorder has disastrous effects, of course. It's all consuming. You know, their time is just spent with that because that's how their brain is telling them to go. It leads to dangerous activities that they normally wouldn't do unless they had that rewiring of their brain. It's, of course, it leads to financial losses. They lose their homes, their cars, their employment. It's debilitating both emotionally and physically. So we all kind of have heard of the physical withdrawal that they have of these chemicals, but patients often feel like they're going to die from this, so that they really need to make themselves feel normal, better by continuing to use. And it increases the risks of communicable diseases like HIV, hepatitis C. There's significant medical consequences. So they come into the emergency department. I've seen significant wounds and sepsis. That's where the blood infection goes throughout the entire body. And people can die from that, of course. Strokes in very young people, heart attacks in very young people, and heart disease just all the way around. They have infections of the heart and heart failure. So those are just to name a few. And the population that is affected by substance use disorder has a high risk of incarceration and legal issues. They have a significant dysfunction in their family, and that leads to a lot of despair from the family unit and just the whole community, really. There's an increased need for social resources, including like foster care. So what I hope to help everybody understand is that substance use disorder is a disease like any other disease, and it should be treated as such. So it is a primary chronic disease of the brain. It affects the circuitry of the brain. It's a genetic disease. It also has a component of the environment in the individual's life experiences. And above all, it's not a character flaw. It's preventable. It's a biological disease, and it is treatable. And people with substance use disorders have these compulsion to continue to use, and it's not just in their head. It's actually furthered by biological processes to seek the substances to make them feel normal. Often a person continues to use substances just to prevent themselves from being sick. So any person, no matter who you are, if you're on these substances for any length of time, which varies between individual, but will become dependent on it. So it doesn't matter who you are, that does occur in everybody's body. And the sickness from that is, like I said, debilitating. So there's genetic components to it. So there's often they're significantly highly likely to have that condition if their parents or grandparents have had this. So it's not just what they've learned in the household, but also a genetic component. And just like any disease, sometimes there's remissions and sometimes there's return to occurrence. So a recurrence of use is not a sign of failure. So we don't want the person to feel like that's one and done. At BrightView, we don't have 3 strikes and you're out. We don't punish patients for keeping, if they have something that's not expected in their urine, or and that really opens up the lines of communications. When a patient doesn't think they're going to be kicked out, they don't feel the need to hide, and they're more open, and we can get to the kind of the meat of what's happening and kind of help them with this. So this is just a diagram of the simplification of in the brain, the process of addiction. So that is on the left. It is involved in certain different areas of the brain, and they're all interconnected. So there's reward pathways, and there's the ones that are avoiding pain. So it all plays into that, as well as intoxication and the dopamine release. On the right is another diagram just to kind of show a cascade of the effects that are happening. And these are such like the neuroinflammation and neurodisease, nerve damage that happens. Here's some pictures. On the left box is on the left-hand side are normal functioning brains. And then on the right is a comparison of those on those substances listed there. This is the dopamine receptors. So as you can see, what happens over time when people are using these substances that cause an excess of the dopamine release, what happens is the body tries to account for that because they know it's not normal. The brain knows it's not normal. So it downregulates, it stops producing a lot of those receptors. So those receptors become less functional and less available in that person's body. So they don't feel normal. I mean, dopamine is a chemical that we all need to feel good, just to feel like we're normal. So the people don't feel that way. So they actually often look for something to make them feel more normal. On the right is a picture showing the metabolism of the brain, and you can see it in comparison to a damaged heart. So you can really see that this is a biological disease. It really affects the organ. And that's what I hope that everybody kind of understands, that it's not just in their head or a character flaw. So understanding it as a disease, we want to reduce the stigma associated with it. We certainly wouldn't necessarily have that stigma for somebody who has Parkinson's disease or diabetes or anything like that. So we want to treat it as a disease and not that it is the character flaw of a person. Because when a person has that stigma associated with their condition, they're going to be less likely to seek treatment. So that's probably playing into a portion of that population that only 10% seek treatment. I can say, working in the emergency department many years ago, I would admit that I didn't always feel as understanding when they were coming into the emergency department time and time again. So what we're trying to do is we're trying to treat that disease so they don't have to go to the emergency department. Language truly influences people and impacts lives. So what we hope is that we can be respectful when we're talking about the disease and talking to the people in a non-judgmental fashion, because people really truly deserve to be treated with respect and dignity. The QR code here works. If your phone is able to zoom in on it, it actually will download a pamphlet that we have that talks about different types of terms that we can use for instead of a derogatory term in substance use disorder. And I hope it works for you guys. If we want to get away from using terms addicted, addict, IV drug user, a drunk, alcoholic, and really call it what it is: an alcohol use disorder, an opiate use disorder, a stimulant use disorder. So that will really go a long way to helping the person understand that it is a disease and it's not them. Because a person is a person, they're not their disease. I hear so many patients who come to me and they use that language themselves. And that is so heart-wrenching to me, because they use those terms that they are less, they feel like they call themselves an addict, and they're not. It's the disease. So I really try to express to them not to feel that way. This slide shows the horrific crisis of the opioid crisis. You can see this is from 1999 to 2021, and you can see the exponential rise in overdoses. And we'll kind of talk about the influencing factors of the substances that we're having to worry with fentanyl. In this graph, the different waves of the opiate crisis. So it started, if you will, the first wave of the opioid crisis, according to the authors of this paper, it really started around the year of 2000. So the green is prescription opiates, and the purple is heroin. The blue is fentanyl, and the red is fentanyl plus a stimulant. So that's either cocaine or methamphetamine. So what happened was in 1999 or in the early 2000s, there was a rise in prescription opiate use disorder, which is, or opiate use, which is no shock to everybody in this room, because here in Portsmouth, you were pretty much an epicenter. We were near Appalachia, where this opiate crisis really exploded. And there were a lot of people that were prescribed these opiates. And doctors at the time really didn't feel like they were doing a disservice. They thought that the long-acting opiate that had come out around that time was less addictive. And when they found out that it was still addictive, then the pendulum swung the other way. And what happened was then doctors quit prescribing it. And then the patients who were already dependent on this, at any age, really, we have a lot of patients at BrightView that are much older, because they were prescribed opiates back at that time. Their doctor quit prescribing it, and they were left to fend for themselves. So the second wave speaks to that, where the people went out and looked for something on maybe illicit opiate use, but with the decrease in the prescriptions, so there was also a decrease in the illicit amount of pills on the street. So the second wave in about 2010 started, where you could see the heroin rise, and people were actually going out and not finding the opiates as much as they were, and if they were real expensive. So they saw that heroin was actually much, much cheaper for them to do. It gave them more of an effect. So that was likely a consideration of that increase there. Then in about 2013, we started seeing more and more overdoses, and they were testing positive for fentanyl. And that rise kind of makes sense from the suppliers of the drugs, that fentanyl is much cheaper to make. It's much easier to hide. It doesn't have to deal with the growing season of the poppy, which is the source of heroin. So it was a no-brainer. It was cheaper. So that pretty much has overtaken the supply out there now. It's really extraordinarily rare, if ever, we find fentanyl in a person's drug screen or postmortem. And the The fourth wave, what I'm hearing from patients is that increase with the fentanyl with stimulants. Most of the patients will say that they don't like fentanyl as much as they liked heroin. It has more negative effects. It lasts longer. So they will often seek out that with a combination of either cocaine or methamphetamine. So to help with those other, the other symptoms that they're having. Not only that, but now there's contamination in all the everything out there now. So even marijuana is contaminated now very often with cocaine or methamphetamine or fentanyl. So it's I keep telling them that it's really nothing's really safe out there. Really. These charts, the first one's a little bit busy, so it just shows the African Americans, the Hispanic, the Caucasian, and the American Indian races. And you can just see from 1999 to 2021, the take home from this graph is that all of them are increased now. So it doesn't matter your race, that it's really significantly higher. The other graph here is showing the drug overdoses for mortality. And you can see the exponential rise after 2019. So blue and the purple are chemicals that have fentanyl in it. So the one has fentanyl with stimulants and the other is just fentanyl. The red is just stimulants only, so it's just cocaine or just methamphetamine. And the yellow are other substances without any fentanyl. So it could be just opiates or something else. So you can see the significant increase in the blue and the purple in the years now. This is from 2010 to 2021. So you can see that the significant increase that we're dealing with. And here's a schematic of the it's again, no surprise to this room, the teen, and this was data population that is affected. So the darker red, the higher the population. And where we are here is very close to the border of West Virginia, so significantly high. Older adults. So I wanted people to understand it's not just young people. I have 80-year-olds in practice. It has been around for a long time. Opiate use disorder has been around for a long time. But our opiate crisis now is significant. You feel these patients who were aged 60 in the early 2000s, they were prescribed a lot of the prescriptions for pain. So the different colors are the different races. So again, it doesn't discriminate for age or race. So the taupe color is African American. The green is Caucasian. The gray, I don't know if you were able to really distinguish a lot of the colors. They used a lot of ones that are very similar. And then the Hispanic is the lighter green. If you can. So touching on the current drug trends, we already talked about there's a lot of contamination with all of these substances on the street. A person who's buying one thing is most often contaminated. And we see that so often. Patients come in and we get a drug screen and we get a confirmatory test that shows so many different chemicals, and they are really surprised at what's in there. And a lot of them say, I've never touched that stuff. And but it's mixed. So unfortunately, I had a woman who was very stable with opiate use disorder. She continued to use marijuana, and she started testing positive for methamphetamine, and she swore that she didn't use methamphetamine. And the more I saw her and the more we talked, I said, I think this may likely be then a contaminant in your marijuana. And she's like, oh no, I know this guy, he's my friend. So as time went on, she started to feel more fatigued. She needed more of that methamphetamine to get her going. Because if we talked about those downregulation in the brain was so used to this high amount of dopamine that the methamphetamine was producing. When She tried to switch dealers just because she thought, she finally believed it was happening. She said, I can't do it. She said, I have to go back to that other marijuana because that's the only way I can function. So she does have a happy ending. I mean, we've worked with her. She's been with us still for a long time, and she has really improved. Unfortunately, there's no medication for methamphetamine in particular, like there is for opiate use disorder and for alcohol. And we'll talk a little bit more about that. The other trends we're seeing is, of course, fentanyl is significantly more potent. As you could see by the overdoses that we saw on those charts, those previous charts, you could see the exponential rate increase in deaths. That just proves the potency of fentanyl. And you can see here too with the doses that were comparison of an analogy toward the amounts that could be required to really kill somebody. The biggest thing too is when they're using fentanyl on the streets, they don't really know what they're getting. There's all different types of analytes. You probably have heard of the elephant tranquilizer, carfentanil. There's all different types of fentanyl. So the person really never knows what they're getting. They don't know the milligrams. They don't know the strength. So sometimes the dose that they had used before is a completely different fentanyl, and they can die. So the potency of fentanyl is far more than heroin. So you've probably heard the word tranq. So that's fentanyl plus xylazine. We are seeing a lot of xylazine now infiltrating into the fentanyl supply. So, and that is just another component. They're kind of why they're putting it in there. No one really knows. It was it's a veterinary formulation. So it's a sedative that vets use for animals, and it kind of made its way into it. So unfortunately, that has led itself to a lot of additional complications, medical complications, such as withdrawal from that, which is separate from the opiate. Also significant wounds that are horrific. So, which can lead to sepsis and loss of limbs too. There's also something called designer benzodiazepines. So there's a lot of benzodiazepines now that are available on the web. So people can go and look and find a lot of these substances online, and their names, it sounds similar to us, but again, their potency differs. So there's so many out there it's hard to even imagine. And they get them a lot of times from other countries that may have them approved for use in animals or humans. And another danger of that is that they never know what the potency is. They never know what's in it. And we talked about the contaminants in illicit substances already. So I want to kind of say that there is hope. The brain here that you can see, the far left is a brain of a normal functioning brain, and then you can see the dopamine receptors are very low in that person with methamphetamine use disorder in the middle. But after about 14 months of abstinence, the brain can repair itself. So that's what I love to tell patients, is that either they don't have to deal with this for the rest of their lives. There can be complications that lead into that last, but the brain can and will recover. And here's just a story of one of our patients.
I've been an addict for pretty much all my life, but I got clean, and I was clean for 4 or 5 years, doing really good. And then when my mom passed away, I just kind of lost connection with everything, and started using again, and, sheltered myself away from people. At one point, I'm sure it's it's been 4 or 5 months I've been coming here, and I'm still failing a drug test. I was really struggling, but they really stuck it out. I kept telling them I really wanted to get clean, and they wrote it out with me, even probably against their better judgment. But in the end, it all worked out. When I first started coming here, me and my dad worked together. We had a business together, and my dad didn't even know I had to use it. I was hiding from everybody. And, that was my first step, was to allow my dad to be a part of it and let him know that I was was trying to get help when I was back in you. So that made, I just kept they kept helping me break down walls and holding me back from actually getting clean. My daughter, she grew up with my addiction when I was younger. She grew up through my addiction the first time I went through all this. And I went to prison for 5 years. I was clean. So when I came home, I didn't good, until my mom passed away. But she knew the signs, So she started going back, not letting me see the grandkids without if my wife wasn't around or I couldn't have them. So now, I get he goes to work with me and I got a better relationship with my kids and everything. My son and my daughter, but my son, we had no relationship at all really because I missed a lot of his life when I was in prison and stuff. So now, he's seen that I've conquered this again and everything. So he just got married, and his wife come over. I got a relationship with him again, them pushed me to reach out to him and start trying to build that relationship. It's really, it's made everything so much better.
It'd be like to have that relationship.
It's nice. I just, before I just always had this bad guilt, and it really, it kept me in a depression because I was always feeling so much guilt because I wasn't there for him. And now, for him to come and be a part of my life, that's a big relief for me to not have to have, because I always felt like our relationship was because I wasn't a good enough person for him to want to be around, I owe a lot of it to BrightView because they just stuck with me when they probably should have ran me off the wall before before I actually got clean. It was really good to me. It's like family, really. They're all really good people. I mean, they helped me with my mental health. They helped me with my health. They got me into my doctors and sent me to specialists. They sent me to a heart specialist when I had a irregular heartbeat, and I got all that straightened out. I've never had a bad moment here as far as coming in and, them looking down on me or making me feel like a bad person, no matter what I'm doing or what.
Family, their job, their house, their car. So it's wonderful. And then people contribute to society. So it's a wonderful thing for everybody. So what can we do? There are ways to recover from substance use disorder. What's available? There are FDA approved medications, and I don't want anybody to think that it's trading one drug for another. These are FDA approved medications, just like there are FDA approved medications for diabetes, Parkinson's disease, whatever it is. They work in different mechanisms. So we have some different tools in our toolbox, and not one thing works for everybody. There is methadone, there is buprenorphine products, and there's naltrexone for the use of opiate use disorder. So methadone works in a way that it goes onto that opiate receptor and it turns it on all the way. So the person can feel better. They can, it's actually a good medication for those who do have maybe chronic pain issues, because it does help with that a little bit better. So there's a different choice for people. We kind of do it individualized. Then the buprenorphine products, so there's the ones with naloxone and ones without it. But the buprenorphine actually goes onto that opiate receptor and turns it on partially. So it doesn't have as high of an effect, like the person wouldn't feel that euphoria as much either. So it's a very safe medication. There's a ceiling effect of the respiration depression that you get from any opiate. So any opiates that you overdose is that you stop breathing. So the Suboxone is so safe that once you get up to a certain dose, that any higher, it doesn't cause any more respiratory depression. So it's actually it's super safe that way. So that when you have them, if a person's on a higher dose, they're not more likely to have their breathing affected anymore. The naltrexone is the total blocker, so it goes onto that opiate receptor, but it completely blocks it. So it doesn't turn it on at all. So they don't feel anything from it at all. It's not an opiate, so there's no dependence on it. With the other products, what we do is after when a person is stabilized, when they have reached their recovery, and as you can see, it takes at least 14 months for the brain to really start to produce that dopamine like it's supposed to. So until then, really, you need a little bit of help. So, and some people will be on it for a long, long, long time because they have that genetic component in their family that it's really the safest thing for them. So if they're stable on it and they can function in society, so some will stay on it for a long time. Others will come off of it, and we help them taper down when they're ready. And then the biggest thing is you want to be there for the people when they are tapering down too. So it doesn't mean that the disease is completely gone, because different things can happen in a person's life and they may need that. They may feel like they need to revert to that again. So there's a lot of things that happen, triggers that happen that we want to be there for. For alcohol use disorder, there's 3 medications as well. Naltrexone also is, even though it goes on the opiate receptor, it does help with the addiction part of the brain. For alcohol use disorder, so it's indicated for through the FDA for both disorders. And acamprosate is something that kind of helps with the jitteriness or the agitation a person has with alcohol withdrawal. You can use them both at the same time. I often do with patients. And the last one we don't usually use very often. It's called disulfiram or Antabuse. You might have heard that. It's kind of like a really old school medication that makes the person sick. So the body doesn't break down alcohol like it normally would, and there's a higher amount of the chemicals that don't make us feel good if we drink too much alcohol. So that contributes to the person being sick. But what we found is that negative reinforcement, it may help short term, but it doesn't really help long term. So we don't like to use negative reinforcement for people. So we don't often use that. I think I've prescribed it once, and it was not for very long for a person because they wanted it, and it just didn't really work out as well as what they thought it would anyway for alcohol use disorder. Unfortunately, with methamphetamine and cocaine, there's not as easy answers. There's really no FDA-approved medications for those disorders. There are some things that we can use. We've tried off-label to help, and I have had some really good responses from some of the people for that. In addition to all of these medications, counseling. So no matter what we give for the medication, it's so important to have that other aspect to what recovery can do for the community. It kind of goes without saying. We bring people that suffer from use disorders back to feeling like they should, back to their old self, back to people who will feel well enough to contribute to their family, work, and so it truly saves lives. If we can increase awareness and access for people, that's what we really hope. We want to increase that 10% to. We would love to have a whole 100% of the people with opiate use disorder seek treatment. So that's our goal, obviously. This will obviously create safer communities because the people who are affected with this disorder kind of have to find it somewhere. They may not have their jobs anymore, so they may have to find funds other ways, so theft. So it's just a win-win for everybody. Improved public health as well, seeing less of those infections. One person who has hepatitis C will actually typically transmit that to 20 people in their lifetime. So what we want to do is decrease that. So they've had an overdose and you give them Narcan and we hope they survive. So we want to increase education. We want to make sure that everybody understands that it's a disease process and it's not a failing of their morality, or it's not something that they choose to do. Naloxone or Cloxato, there's a couple different for it, but the reversal agent, and that disorders, whether it's cocaine or alcohol, to their friends, their spouses. They are people, and they don't deserve this. So more support from social services, legislation, and communities, and the reduced stigma effect will really, like I said, change lives. So as providers, I think there's some providers too that we would love to have more people educated on addiction. Like I said before, I wasn't really taught it in medical school. I think that was many years ago. So I'm hoping that they're doing more now, and I'm sure that they are. The social support, if we can help with assisting them with the other needs that they have, because they've lost a lot in their life. If we can get them assistance with nutrition and clothing, temporary shelter and housing, access to treatments like we talked about before with getting from the emergency department to a treatment center, access to services perhaps online, telehealth services that was one of the good things that have come out from COVID-19 pandemic. Feature home and not have to worry about, because a lot of them don't have transportation. So working with the judicial system, hopefully we can help with that. We do work with criminal justice partners. So in many sectors, we have police officers who know where to tell a person to go if they if they're having some legal issues. And we've worked with judges and courts. We have helped people comply with what they're also told to do. So I have a patient who said that she had been referred to opiate programs in the past from courts. She had been court ordered to go. And she said numerous times. And for some reason, this time coming to BrightView, she said she got on medication and she felt that it really helped her. She said this really stuck. She's been sober for 2 years now. And I don't want us to take all the credit, of course. Sometimes it's where a person is in their life, but also we do, like that person said, that our patient said, we want them to be a welcome. We want them to be welcomed when they walk into the room. Another case that I have, that another person who is a reverend, and he is in his 70s. So he had gotten dependent on opiates, being prescribed it for back pain many years ago. And he said, I wish I had known what it was going to do to me. I would have never taken that pain pill. He said, I would have dealt with the pain. So it led down the path that he didn't anticipate, but he has been sober now for 3 years, and he is somebody who works with his own church to help people understand that it can affect anybody. He said to me once, he said, when I drive on and park my car and walk in, he said, I feel the sense of relief, because he says, I know nobody's going to treat me poorly. He's still afraid to sometimes tell his story to some people, but he says that he just feels that when people treat him with respect and understanding, they feel it, they know it, they know you're genuine, and they know you're not genuine. So that's what I tell patients. I said, if there's anybody in our facility at all that doesn't treat you that way, please let us know, because we don't want that. So we want to also promote the awareness and the availability of harm reduction. Harm reduction means a lot of different things to a lot of different people. The harm reduction things that you may have heard about are syringe exchanges, clean needle programs. It does drive down the spread of the disease. Unfortunately, not everybody's ready or has access to treatment. So if and when they use, the safest thing, and again, to reduce the transmission of diseases in our community and the horrific effects of it, is these clean needle programs. And supervised injection sites, that's very controversial too, when you're talking about the harm reduction techniques. I know in New York, they have a lot of them, in California. where people can go and there's somebody there to help them understand a way of doing it in a less risky fashion, if that makes sense. Fentanyl test strips, they also have xylazine test strips as well, so that they kind of know what they're getting. And then having naloxone available everywhere, of course. Now you can get it in a pharmacy without a prescription. So anybody can go to a pharmacy. If you're a mother, a grandparent, a friend, a spouse, you can go to the pharmacy and ask them for a Narcan, and you can get it dispensed to you. So you can have it. So we already talked about a lot of this. All of these together, plus the decreased stigma, is really going to work together to reduce the harmful effects of substance use disorder. And I think knowing if you have the chance to save somebody, in doing so, that person's life can be turned around completely. Like the gentleman that we saw, he didn't deserve to die at any point in his life. So for anybody like him, please think of them as a person, and they're not always going to be happy if you reverse them, because they're going to wake up and they're going to feel really sick. However, they're alive, and we have so many death stories of people who were revived with Narcan or naloxone, and they just get treatment, they get healed, they get their life back, and they're a whole different person. So signs of overdoses, you look for, is the pinpoint pupils, if they have decreased respiration, so they're not breathing normal, if you can see bluish discoloration, if they, but the biggest thing is you're not going to hurt them. So if they've overdosed from something else, you're still not going to hurt them. So the only thing you can do is save a life. So if they have passed out or from some other reason, from a heart attack or something else, again, it's still not going to hurt them. So we encourage everybody to use it if they think that there's a possibility of an overdose. The onset of action of naloxone or Narcan is just minutes, like 2 minutes, but it only lasts for so long. So unfortunately, it actually wears off before a lot of the illicit substances like the illicit opiates do. So fentanyl lasts far longer. So we encourage everybody to call 911 or call the EMS regardless if the person wakes up, because what happens is everybody leaves and everybody thinks that everything is okay, and that person can go back into an overdose and die with nobody available there. Plus, getting them to the resources that they need. They may have had another injury too that occurred, and of course, the brain is damaged after 3 minutes without oxygen. So the faster we can get that into them. So if everybody had naloxone with them, I think a lot of people would really be saved. So naloxone is the reversal agent. So it goes onto those opiate receptors we talked about before, and it actually will throw the other chemical off of it. So it reverses the opiates. It doesn't reverse benzodiazepines. It doesn't reverse cocaine. It doesn't reverse alcohol. But if it is a combination of factors, if sometimes just reversing the opiate is enough to save that person's life, even if they have other substances in their system. There's a lot of brand names, so I apologize for keep saying Narcan, but Cloxato is another one too. That's a double of the dose of Narcan. So it's instead of 4 milligrams, it's 8 milligrams. Because with the potency of fentanyl, we see the need for a lot more than just one. So in the emergency department, when fentanyl was first coming out, we were seeing that Narcan just wasn't seemingly working. So we thought maybe it was something else. Once we started seeing that it was fentanyl, we started understanding that you need a lot more naloxone to reverse this. So in the early years, we were exhausting our resources. We used up all our Narcan, so we understood that you needed more of it to reverse it. So multiple doses are often needed. Here's a few just patient reports after being revived with Narcan. I don't know. You're probably not able to read that. But the one said, I had been in a coma. Most people, as lucky and blessed as I have been, I know a lot of people who have fallen out once and are no longer here. The other person said, above anything, you are amazing for what you did. Don't ever let someone shame you for saving their life. People get mad at you for ruining their buzz. In fact, they are unresponsive in an overdose. You are so amazing for what you do. And this other person said, after waking up from an overdose, I am agitated and usually arguing and being defensive about using and trying any way I can to get away from them. So I can go and do the same, quote, dumb thing again. This has been my life for many years, and I'm so grateful to have another chance to recover here. So this last slide is that, like I said, the resuscitation isn't the end of the story. We want to get people to get treated. Without treatment, they're not necessarily going to be able to stop. Again, it's a disease that they just can't overcome, sometimes without any kind of assistance, without medication, without counseling. And if we could have those resources available, that would be that is wonderful. Having a warm handoff and helping that person get to where they can go, where they're going to get treatment is going to ultimately help them heal. Does anybody have any questions, any stories, anything that they wanted to ask about current drug trends, anything like that? The one thing I wanted to mention is with the medications that we use, methadone, buprenorphine products, you have seen that the significant rise in overdoses from patients. That speaks to how potent it is. And you saw that one slide where the size of a little tiny piece of rice is the equivalent of a lot larger amount of heroin that's needed to kill somebody. What we're seeing is that potency for fentanyl is really far exceeding sometimes what we think is a normal treatment. So the medications that we have right now, sometimes we are having to go in doses higher. And I kind of equate it to antibiotic resistance. I'm not sure if anybody's had a sinus infection anytime recently, but about 20 years ago, you just needed Augmentin 875 milligrams for your sinusitis. Now you need Augmentin 2 grams because of the antibiotic resistance that's happened. It's kind of similar, but in a different sense with the potency that we're talking about. So the people who have the dependence on fentanyl really, really hate that negative effect, hate that it lasts days instead of one day. And so it's a challenge that we're up for taking on. And I thank you all for being here too, and being interested enough to listen, and those of you that are attending virtually too. So I appreciate everybody's time and interest. But I'll stay after too if anybody has any questions that they want to talk about. So thank you guys.